of every step of the way what you're kind of performing. So now let's talk about what. So you'd be like, hello, John, I've been asked to discuss the examination with you. Or, hey, Sarah, the medical student, I've been asked to explain to you the next patient I'm going to examine. So wash your hands, introduce yourself, talk to the patient, tell the patient what you're doing, explain, and exposure. Then always in every examination that we go through, most important, it's check for pain. So are you in any pain? Could you point to where you're in any pain, or you ask them, do you want any pain medications before we start? Then start off with vitals. Here you're also doing BMI of to differentiate between hyper and hypothyroidism. And always, this is the standard format. After you do BMI vitals, then general examination. Are they comfortable? Are they restless? Do they look anxious? Are they dressed appropriately for the weather? Then after that, we talk. So as we spoke about, it's always kind of peripheries. You do hands, arms, and then come to the face, rest of the body, or the focused in here, it will be thyroid examination and then lower limbs. So it's kind of the cycle that you do for any system examination. So as I've briefly mentioned last time, they can ask you to do a dedicated thyroid examination or examine a patient with these symptoms. So that's what we're doing in this class, because the more you learn in the exam, you can shorten it down. If they say just do a thyroid examination, you would briefly say, I do general examination, examine the rest of the body, but focus on the thyroid. Online exam, because you're talking and you're not actually doing the exam, they'll expect you to talk about everything. So both hypo and hyperthyroidism features, as well as all the other relevant systems you would examine when a thyroid patient comes. So now coming back to the hands. In hands, what are we looking for? First one is palmar erythema, which we can see in the first picture, and you feel for the arms if they're warm and sweaty. Then oncholysis, this is when there's the separation. So you've got the nail bed that separates, or the nail that separates from the nail bed. Particularly in the ring fingers, what we're looking for, and sometimes it can kind of be apparent due to like sympathetic overactivity. Then we will move on to the next one. Then you're going to look for thyroid acropatchy. So what is this? So it's similar to clubbing, but it results because there is an overgrowth of the periosteal bone, and that's why you can see the swelling. So you can see in this picture with the arrow, it looks kind of like clubbing. And then the final thing we test for is fine tremors. So you use a piece of paper and test 1 second. I'm just going to... Sorry, guys, it's just my dog who's making a lot of noise. Next, we'll move on to the arms. So we've done with the hands and now in the arms. So first thing we look for is radial pulse. So you're looking for both rate and rhythm. After that, you look for proximal myopathy. So how do you ask them to do this? The easiest, simple way is chicken hands, or chicken wings. So ask them to flex their hands at the elbows and then to kind of abduct and adduct. That'll look for proximal myopathy. You can add pressure and give them resistance, again, checking for that. And next is checking for reflexes in the arm. Now coming to the eye. So eye is the most important in the sense that we always talk about the eye signs. So this obviously the examiner expects you to know well and know all of them. So first you as examination goes, you divide it into kind of inspection versus palpation, and then later signs. So on inspection, you're looking for any ulcers, any redness, any hue, chemosis, first up. And then the next one is these special signs. First one is the Dalrymple sign. So this is looking for lid retraction. So where the sclera is visible above the iris. So you just ask them to look straight, and then you can see a lot more of the white part in the eye, even above the iris on either side of the iris. Next thing after that we look for is the lid lag or graphy sign. So how we do that is you stand in front of them, and it's like in ocular examination how we do the H. It's similar, but this is up and down. So you ask them to follow your finger from up to down, and you can see that the lid kind of delays between the ocular movement. So the eye and the pupil will move, but the lid will be kind of delaying or a bit later than the eye. So this is a very common sign that we can see when we're moving the eye down. Next one is ophthalmoplegia. So this is again checked by ocular movement. So do the H. So you can do up, down, and then do your H movement for eye examination. And you can see there's a delay in this movement. And the next one, which is the most important, is the exophthalmos. So this is the protrusion of the orbit. Most important is when you're looking for exophthalmos, you need to stand behind the patient. So these are the things that the examiner is going to wait to catch you out. So did they say that you're going to stand behind the patient? Then you say, I'm going to stand behind the patient, get them to kind of tilt their head, and then you're going to look over their forehead to see if there is any protrusion of the eye. Okay. Let's go to the next one. So the next part of this examination is the neck. So this is the most important part of thyroid examination. So it's examining the actual gland. So normally you first inspect the gland, and it should be in the middle of the neck. And when you're inspecting, obviously in face to face, you have to make it a scene that you look from the front and the side of the patient. When you're explaining to this medical student, you have to say the same thing. So inspection, it's important that we look not just from the front of the patient, from either side, to look for how big the swelling is, if it's obviously there's a swollen gland, and how the skin overlying the thyroid or neck area is, if there's any scars, any redness, any rash, or dilated veins. And so apart from that, if there is a swelling visible on inspection, then you need to ask them to do the following maneuvers. The first one is the swallow test. So you give them a glass of water to take a sip on, and you observe for any movement. Firstly, if you can see a mass, only then will you give them some water. So thyroid, either if it's a goiter or a thyroglossal cyst, then you can see movement. So in this kind of, if you're explaining it for someone online, before you start, you'll let your medical student know we have to make sure we've got a glass of water for a thyroid examination. Then the next kind of special test for thyroid examination is the protrusion of the tongue. So if it's a thyroglossal cyst, then when you protrude the tongue, you can see that the whole gland moves upwards. So what is this thyroglossal cyst? So this is kind of the next step in online examination, which is what I've seen a lot of people fail because they don't do that next step. So if it's a medical student, you're teaching them. You're not just running through like a documentary of every step you're going to do. So you should always add kind of a bit of information about why you're examining. Like I'm inspecting for redness if it's thyroiditis. I'm doing the tongue protrusion test because of thyroglossal cyst. So medical student, you know what a thyroglossal cyst is. So it's a midline mass that can present at any age, but it's normally an embryological remnant of the thyroid duct. So that is for a medical student. But let's say you're teaching the patient itself, and then you're trying to explain to it. That's when you say it's a lump in the neck. That's because of tissues that normally develop into the thyroid, stop doing that in the development stage, and then they form this lump or something along those lines. So either or, always add in some commentary while you're doing these examinations, because even though you've got about 8 minutes, you will have time. Next, after that, we talk about palpation. So palpation is important in the sense that we'll have to, again, palpate from the back of the patient. So first thing is temperature is from the front. So you feel with the back of your palms, feel for any a local rise in temperature. Then most of thyroid examination, at least the palpation part, should be behind the patient. So stand behind, as you can see in this picture. And the first thing you're looking for is mass and tenderness. So you palpate. So you use your three fingers as in this picture, and you palpate the gland for one, if there's any mass, is there any asymmetry, is it irregular, or any tenderness. So how you start is three fingers kind of in the midline, and then you palpate laterally to tell us the extent. And also you kind of come down from below the chin to see the top upper border, and from the Adam's apple in men. And then you look from the kind of cricoid cartilage down. So you're feeling for all four borders. So start in the middle, go sideways, and then from the top you come down, and then from the bottom inferiorly until you reach the cricoid cartilage. So remember to explain these when you tell the medical student. So you're looking for all four borders. So that's another thing I wanted to stress. When you're explaining to medical student or the patient, don't say I'm going to examine all sides. I'm going to examine all the borders of the thyroid gland. That's 2 seconds, you're finished. But that's not going to explain how you're doing it. And that's what the examiner is trying to check. So I'm going to examine the thyroid gland by first starting with my three fingers in the midline. Then I'm going to start slowly palpating laterally until I can feel the lateral borders of the mass of the thyroid gland. Then I will start from the chin and then kind of palpate inferiorly or palpate going downwards until I feel the Adam's apple or thyroid cartilage. And then from the bottom, I'm going to, or sternum, I'm going to, or not even, yeah, from the sternum, I'm going to palpate upwards until I feel the cricoid cartilage or cricoid ring. So you have to explain how you're going to do that. Then again, you need to ask for the patient to swallow. Now you're feeling for symmetrical elevation. So same thing, previously you look for it, now you're going to feel for symmetrical elevation of the thyroid lobes. Firstly, if it's asymmetrically elevated, then you might think it's a unilateral mass or a unilateral, a lobe or a nodule on just one side of the thyroid. Then same thing, you ask them to protrude their tongue, and then if there is any masses, again for thyroglossal cyst, you can feel it kind of rising as you palpate for it. So here's the picture. Now, when assessing any mass, not only thyroid, there's a few more things for thyroid, but the rule is first you find the site. So is it on one side or is it on both the sides? Or is it uniformly enlarged? Then the size of it. So roughly the thyroid mesh is 5 centimeters, 2 centimeters, whatever the size is. Is a single or multiple in number. So here the gland itself not going to be multiple, but at least you can get multiple nodules. So that could be something you'd mention. Then you talk about the borders. Are they regular or irregular? Consistency, firm, hard, could point towards malignancy. Soft or cystic could point towards, collection, inflammation, and mobility. Is it fixed or is it mobile? And then always remember, we're doing a complete examination of a symptom. So it's not just thyroid examination. If it was thyroid examination, you would stop at this protrusion of the tongue. But since we're doing a complete examination, you have to say the next thing you'll examine is cervical lymph nodes. So we have another kind of session on cervical lymph nodes. So I'm not going to go through it too much today. Next, we talk about percussion. So percussion, obviously percussion, palpation, all these, the gland has to be palpable. So only if it's palpable, you move on to percussion. And as you can see in this picture, this is also done from the back. So make sure you tell the medical student that, so next we're going to move on to percussion. You can ask them a question. Have you ever done percussion before? Do you know how it works? So don't feel like you're wasting time in this. You should always involve the medical student. And that's, I feel that was my first time when I didn't clear. That was the mistake. I knew what I wanted to present and I just went on talking about it, like the step, okay, percussion, then I'm going to talk about, auscultation. This is my performer. But this is, you're graded on how well you're teaching and how well you understand the procedure. So always check. Do you understand? Do you have any questions? Medical student Sarah, do you have any questions? Or do you know what percussion is? Have you ever done it? And then she'll be like, oh yeah, yes. Most of the time she will say no. So they've got some fixed cues, the role players. So don't feel like, oh, now I have to go back and teach them. That's a good, you'll be like, this is how you do percussion. So you're adding some more information to that case. So what you have to palpate and then percuss the sternum first, and then you move down. So you're not actually percussing the gland as such, but you're looking for retrosternal extension. So you got kind of the upper border of sternum, and then you start percussing downwards from the sternal notch, because you're looking for retro sternal dullness. So if there is retrosternal dullness, it points that the thyroid is so big that now it's gone downwards into the chest. So that's why we're doing this test. Let's move on to the next. Now coming to auscultation. So auscultation. So you're going to auscultate over, most importantly, the lobes of the thyroid, not just the center. A lot of people think they're done. It's both the lateral lobes of the thyroid need to be auscultated, and you're looking for bruit. This is when you can ask, oh, medical student Sarah, do you know what a bruit is? And then you can be like, she'll be like, no, I don't. Then you're like, it's like a wishy or a swishing type of noise that you can hear when you put your stethoscope over this. This shows that there is an increased blood supply that you can see in one being hyperthyroidism, or even people who are already on anti-thyroid drugs. So that's why we do this test. Next important and unique to thyroid examination is what we call the Pemberton sign. So again, if the gland is not visible, then you can skip this. But essentially what you do is you ask the patient to lift both their arms. So both their arms as high as possible above their head, like in this picture. And then you wait a few minutes and look for their face for signs of any congestion. So the plethora or redness, as you can see in picture B. And then sometimes it can start off with plethora and then can extend into cyanosis. So you're looking for that. And sometimes it can be associated with respiratory distress or any inspiratory stridor. So this is what you're looking for. And this will tell us, one, there is a big palpable thyroid. It has retrosternal extension. It's compressing our airway also, and the blood supply to the face and neck. And that's resulting in this cyanosis and redness. Now, as I said, we've finished the hands, we've gone to the arms, then we did the face, and then the neck, which was our focused examination. Rest, we have to complete it. So completion would be lower limb examination. In lower limb examination, firstly, you're looking at the tibia. You're looking for pretibial myxedema. So this is, what is this? Firstly, the skin can initially become shiny, waxy, then later can be indurate and discolored, like in this picture. So it starts to get discolored on the anterior aspect of the leg, as you can see in this picture. Then you do reflexes, so ankle and knee reflex. And we've done proximal myopathy in the arms, and then that was our chicken wings. We can test the same thing in the legs. And how do we do that? Simple, you just ask them to get up from the chair or from the bed without using their arms. So you'd explain it. We'd finish off our examination by looking for, you'll ask the patient to get up, either crossing their arms or hands by themselves, and then get up and see if they're able to do so. So that kind of concludes our examination of this. Is more focused on general, and I've kind of touched more base on hyperthyroidism. We'll talk a little more about hypo in a second. So what is, if they ask you differential diagnosis, so what would be your differential diagnosis for this examination? So you're thinking, firstly, it's hyperthyroidism. So what are they? It could be toxic multinodular goiter. It could be Graves' disease, toxic adenoma. It could be drug-induced. It could be infection, anxiety, hypoglycemia, or pheochromocytoma. So all these are kind of a differential diagnosis for the symptoms. Obviously, when they present you with deranged thyroid function, they won't ask you differential diagnosis, because they've given you blood results. But if they come with a mass, or if they come with symptoms, then these are the differential diagnoses that you need to mention. So this was our hyperthyroidism. Now let's talk about hypothyroidism. So hypothyroidism, when you are asked to do a thyroid examination, and from the few cases that I have seen of the thyroid, if it's an online exam, you need to talk about both hyper and hypothyroidism. So I suggest when you're doing your notes, have two separate columns and write all the differences of each, because when you're explaining, you should be like, if it's hyper, it could be this. If it's hypo, it could be this. So you're telling the medical student, I'm at each stage, like in the hands, I'm going to differentiate it. In the face, I'm going to differentiate it by these signs in the eye. So that's why I've written it like this. So again, when we're starting off any examination, I said we start off with our mnemonic, WIPE, then we do vitals and general examination. Then we come to the specific findings for each. So in the hand, in hyper, it could be moist. This is more dry, coarse skin. They have cold peripheries. You can see tendon xanthomas, which is a picture over here. You can also see that the nails are very brittle. And obviously, you're looking for pulse and blood pressure if you're not done so already in your vital examination. And then coming to the face, again, in the face, it'll be dry, coarse hair. They'll have the loss of the outer aspect of the eyebrows could also be noticed. Then we had a lot of eye signs in hyperthyroidism. In hypothyroidism, it's more general stuff than specific stuff. So there is pallor, jaundice that you would look for in the eye. Then you have xanthelasma, arcus, corneal arcus, periorbital edema, and malar flush. So think of it, it's like a hypothyroid person. He's bloated, very puffy, he's sweaty, he might be a bit jaundiced, he's flushed in the face. It's all like, oh, fluid overloaded kind of picture we need to think about when we're thinking about hypothyroidism. Then voice also, is it deep? Is it cracked? Is it hoarse? You need to talk about the voice. So how would you ask in this? Again, when you're explaining to the medical student, don't just be like, I'm going to ask them for their voice. That's not right. You have to say, I'm going to ask them, tell me their name or address. I'm going to ask a question so that I can assess their voice. So that's how you word it. So as I keep telling everyone, um, physical, not even physical, the whole of AMC is how you present yourself and how you act. So how each word you say should have some meaning, and it's not just you're using it because this is the performer that you learned from Snigdha in a PowerPoint and you're using it. It should all have some sort of implementation in the clinical field. So make sure everything is a statement or a question and not a bullet point. Then coming to the neck. So the neck examination is completely the same. You start with the inspection, then the palpation. Remember to stand behind the patient, percussion, auscultation. So that does not change in hyper and hypothyroidism. And in the lower limb, here you can see that the ankle reflex is delayed to relaxation of the ankle reflex. That's the only kind of extra thing that we have to talk about. Mm. Okay, for everyone after today's class, because it'll be fresh in the mind, if you have some time, please watch the Geeky Medics thyroid examination video. It'll run through how to do it. I know it's online, everyone's like, oh yeah, I just need to know how to say it. Once you've done it, and especially if we've got a gap in, our learning, we sometimes forget of the simple things of how we do an examination. So I always say when you're studying for it, study as if you're going to do it on the patient so that you can explain it to your medical student or whoever, because you know how to do it. So that's how you'll explain it. Now, quickly, I'll run through how you would say this in an online examination. So firstly, you always greet the patient. So, hi, John. It's very nice to meet you. I'm your GP. And today I have the medical student with me first, who would be accompanying me to examine you today. So always tell the patient that you've got someone in the room. Step one. Step two is, hi, Sarah. Which year are you currently studying? Oh, that's so great. It's exciting to be in the clinical field. So I'm happy to show you one of my patients. So today we have so-and-so who's here with a lump in the throat, and he's quite anxious. So we're going to examine him today. So firstly, before I examine him, I like to think about what could be causing the lump in the throat. So firstly, most likely when given his other symptoms of feeling tired, lethargic, it might be the thyroid, but others could be the cervical lymph nodes. It could be another malignancy. It could be a fracture, swelling, non-union of bones. So many things that I would think about. But firstly, we'll during my examination, we'll kind of confirm that is this thyroid enlargement. And as you probably already know in your clinical studies, thyroid, when it has an issue, it could be hypo or hyper. So I'm going to examine to kind of rule out each of those. Now, before we start, we first have to wash our hands, and I've let the patient know to expect you, but we will go and formally introduce ourselves and take proper consent. Then I will explain the procedure briefly to the patient before we start. And Sarah, always remember we need adequate exposure of the examination part before we go ahead. Then we talk about each one. So first is general. Yeah, okay, if we go. So first is general appearance. So we will examine the patient, see how they're looking. If they're in any discomfort, are they in any pain? Then we'll get vitals and BMI. Then we'll do the thyroid examination. As I already said, I'm not going to repeat it. You do your normal thyroid examination. Sarah, after doing the thyroid examination or before, I'd also like to examine other systems that are relevant for our findings. This will include the hand, the arms. I'll also examine the face, especially the eyes. As you know, the eyes are very important in thyroid examination. There's specific signs that we can pick up both for hypo and hyperthyroidism, and this is what I'm looking for. And then I'll finish off by doing a lower limb examination. And as I discussed, in both there is hyper and hypothyroid signs. And then you explain. Sometimes they'll ask you what are the instruments you're going to use in your examination. So as you know, we need paper. Paper is for in the hands for fine tremors. So we'll need a paper. A glass of water is very important when you're examining thyroid. You'll need your tendon hammer for reflexes, and for blood pressure, you need your sphygmomanometer. So that is thyroid examination. Hopefully everyone's understood that and not got any questions.
I've got one question or a comment.
Yeah.
Yeah, concerning the examination for the hyperthyroidism.
Mm-hmm.
Could you also, as part of the examinations of the hands, could you also additionally add the pulse and characterize it, as in if it's regular or irregular, if it's
Mm-hmm.
bounding or yeah, because you know that thyroid is hyperthyroidism can also cause
Bounding.
atrial fibrillation.
Mm-hmm.
I think that can also be an important addition in the examination.
Mm-hmm.
Yeah.
Yes, very well. Yes, that's absolutely right. As a rule, I always put it like vital signs as a separate kind of heading, but you're absolutely right when we're doing hand examination to include it. Why I put it as vital signs, especially for face-to-face examination, the moment you ask for vitals, that's when it kind of determines whether it's going to be a stable or unstable patient. So any kind of hist or any physical examination station, I've kind of taught my brain to always ask vitals and then do the rest. But you're absolutely right. As there are specific signs in the pulse that we can pick up, we have to elaborate on that. That's it. Any other questions, anyone? Okay. Let's move on. So I thought today we're going to do breast examination. So today I'm hoping to cover thyroid, breast, headache, secondary survey, and peripheral vascular disease, or a brief kind of summary of those. So again, if I'm talking too fast or you have any questions, please feel free to stop me and we can go from there. Next, coming to breast examination. So in breast examination, as I keep going on and on, the usual format stays the same. You start off with wipe. Here, chaperone is very important. You ask them for pain, exposure, and general, looking if they're comfortable. So that's the general kind of performer for anyone, especially here. Chaperone's very important. So how would you ask them? So I have been asked if it's so always, as I keep saying, you have to determine or kind of find out where you fit in. Is it a GP setting? Is it an emergency setting? And you should always take the role of that character. And that'll change how you examine and how you present yourself. And that's what the examiner is looking for. at the end of the day, you're going to pass this exam and you're going to work in Australian hospital. Do they know how each hospital kind of works? So for those who don't know, in a GP settings, you don't have resuscitation, you don't have, more extensive kind of equipment to help them out. If anything goes wrong, you need to call the ambulance as you would in the community. So if you're a GP examining, then you're just in your own cubicle. Whereas if it's an emergency setting, you could be in a cubicle, you can be in the resuscitation cubicle, you can also be in the waiting room and just one of the waiting bays. So understanding where you're examining them and how appropriate it is to do this examination is important. So I've been asked to examine your breast today. The examination will involve me to have a look, place my hands and examine the breast, looking for any abnormalities, any masses, and if there's any pain. This will also involve me to examine your armpits to look for, again, masses or swelling there. As I'm going to be doing this examination, I will get one of the female nurse members to be present during this examination, acting as a chaperone. Is that all right for you? So make sure you get consent for that. Or and I know previously old school thought was examiner, can you be my chaperone? Normally, especially in the online examination, they do not like you to interact with the examiner. You don't even see them. They're kind of like a blanked out window. So don't be like, oh, examiner, will you be my chaperone? No. If you give me a second, I'll call the nurse to be my chaperone. Or if you're explaining to the medical student, then I can be your chaperone if you're examining, or you can be my chaperone when I'm examining. So kind of involved, and it's essentially you're acting it out. So just tell them that you're going to get a chaperone. Then at any point, this is very important, especially for delicate examination, is at any point, if you're uncomfortable in any pain, please let me know. We can stop or skip that step. So this needs to be ingrained in your brains. You need to keep saying it all the time. So at the end of the day, they're looking for in examination how kind of understanding and how well you kind of present yourself, in the sense that are you considerate? Are you understanding that they might be uncomfortable? Are you understanding that they might be in pain or in any distress? Then I always like to combine it as I will go wash my hands. In the meantime, would you be able to expose your kind of from waist upwards so that I can examine? Please let me know when you're ready, and then I will step back in. So same thing, you'll tell the medical student. So after this, while we both go and wash our hands, we let the patient expose from the waist up. And once they're ready, they can let us know and we can step back in. Then general examination, we know, are they sitting comfortably or not? There's not much to that. Now coming to inspection. So inspection, or the whole of the breast examination, but in your mind, it should be how the patient is positioned and what you're going to see in each of the positions. So the positions are: one, the hand is by their side. Number two, the hand is kind of above their head. And three, when you're palpating, one hand is behind the head. And or four is when they're leaning forward. So there's four examination kind of positions that you need to make sure the patient's in, and each one will give you different information. So the first one is arms by the side. So position the patient in such a way that their hands are on their thighs and they're relaxed. So you tell the medical student. So the first time you'll ask them to sit on the bed and then with their arms by the side, or the bed's at an 45-degree elevation with their arms by their side and they're relaxed. So in this position, what are we looking for? We're looking for scars, swelling, redness, rash, any asymmetry, any masses, any skin changes. So how you would say this? Remember, this is not bullet points, but I've put it in the PowerPoint as bullet points. But when you're actually presenting, you can be like, I am looking for any scars, if there is any swelling or any redness, if there's any rash. Or you'd be like, on examination, you find that there's no visible asymmetry, there is no masses, no skin changes. So it can be either or. If you're doing the exam or you're teaching the exam, so medical student, what you're looking for. So don't just give bullet points, as I keep saying. And then in skin changes, you talk about puckering, which is the first picture here on this side. Then we've got dimpling, which is the second picture here, and the last one is per day orange. And then any nipple changes. So what are these nipple changes? One is an everted nipple, any scratches, any redness or discharge. Now let's talk about what each of these are. This is again, as I said in the thyroglossal cyst, how you add a little bit. This is you adding a little bit. So don't just stop with puckering, dimpling, or per day orange changes. You need to explain it to your medical student, or even if it's your partner or patient. If you add a little bit more, the examiner knows what you're talking, that you know what you're talking about, and not just memorize these words. So what is puckering? So puckering, as you can see, is like a small indentation in the breast tissue. That you can mostly see it when the patient actually raises their arms, but we look for all these signs in all the position. So it forms a groove, as you can see in the side picture. It forms a groove on the curve of the breast. So puckering is typically kind of gives us information that there is some invasion into the suspensory ligaments. That's the key point, and that's pointing towards malignancy. So puckering is invasion into the suspensory ligaments and kind of pointing towards underlying malignancy. The next one is dimpling. So dimpling again is a visible change and it's like tethered. So there's one point of it, think of it like it's getting pulled underneath. So to the underlying skin. So there's or you see like an indentation or a little pocket that has been formed. Again, you can have multiple of these dimplings, and that's how you get the per day orange appearance, which essentially means it looks like an orange peel. So you can see multiple small dots on it, which is an orange peel appearance. Again, why you get this is because it kind of blocks off the cutaneous blood supply, and it blocks off the lymphatic, and then you have edema surrounding it. So this more suggests like an inflammatory breast cancer, so that it's blocked it off and you've got swelling around it. Next, move on. Two hands on the hip. So we finished relaxed position and then hands on the hip. This is very important to look for mobility. Obviously, you do all these same scars, sinuses, puckering, dimpling. You're looking for the same thing all over again. If you have time and don't have much to say, you repeat all of these again to the medical student saying, I am looking for scar, swelling, redness. But essentially, in this position, you can test movement, and if it's adhered to, if it's more invasive and it's invaded into the pectoralis. So you do the same thing, but focus on movement and look, is it mobile or is it fixed? If it's fixed, then it's pointing towards it kind of being adhered to other structures, especially the pectoralis. So how do you ask them to get into this position? So ask the patient to place both the hands on the hip, but that's not it. They need to squeeze inwards. So you need to actually tense the pectoralis major. So that's the most important thing. So hands on hips is not just it, but you need to tense. Then you repeat the inspection and then again look for masses. If a mass is noted, then you look for the movements. And again, this will suggest malignancy or invasive malignancy. Next, moving on. Next is arms behind the head. So arms behind the head is the third part of inspection. So in this, what you have to ask the patient is, one, could you please place both your hands behind your head and then lean forward? So that's what we need, the breast to be relaxed and kind of acting with gravity so that we can see symmetry. If it's pronounced, if one side is kind of got this invasive mass pulling it back, then you can pick it up better when they've got arms behind the head and leaning forward. So this will expose and exaggerate the symmetry of the breast. If there's any skin dimpling, puckering, tethering, this is the best position to pick those up. And obviously, sometimes the masses, especially the upper outer quadrant masses that are extending into the axilla, become more visible in this position. So that is the third position. Now coming to palpation. So when I've got this image here to kind of explain this. So make sure always in breast examination, start the examination by saying how you're going to position the patient and then say, what are your findings? So in palpation, so firstly, I'm going to make sure the patient has one hand behind the head, the side that I'm going to be examining. The other hand can rest on their thigh and relaxed. So, and then the bed should be at 45 degrees angle. Always start with the normal breast first, and then make sure your hands are warm before you touch them. And if again, confirm that they're not in any pain before you start the examination. And So you're going to compress the breast tissue kind of into the chest wall for feeling for any masses. So you're going and pressing down while you're doing the circular motion in a spiral method for looking for any what do you call it, abnormal tissues. So the spiral method, you always start with the nipple and then you work your way in a circular motion all around. So if you detect a mass, then you stop. Then you ensure you do the complete breast examination of that mass, which is what we'll talk about in a second. So start from the nipple and then go in a circular motion. When you find a mass, you stop and do a full examination. So before I talk about this, most important thing that I've mentioned here is the axillary tail. So make it a point that you explain to the medical student that after your breast examination on both sides, it doesn't stop there. Make sure you examine the axillary tail. So this is when there's just a bit of extended breast tissue into the axilla. So that's the upper outer quadrant. And this is called the axillary tail. So majority of breast cancers actually happen in the upper or outer quadrant. So examining here is very important, or you're going to miss out on that. And the last thing is nipple examination. So nipple examination, if the patient, if they ask you, come with nipple discharge, you should not be expressing it. You ask the patient to, could you please express to show me what the color of the discharge is. And in that, based on the color, so if it's yellow, green, milky, then you can think, is it infective? If it's like bloody discharge, again, pointing more towards a malignancy. Then after you've done the normal side, you do the whole thing on the opposite side, finding the similar findings as above. Now coming to mass. As we spoke about in thyroid, masses are always the same. How you examine them, how you present them should be the same. So the site of the mass and how you state the site of a mass in breast examination is by quadrants. So is it the upper outer, inner upper or inner lower? So what quadrant is the mass in? And how far is it from the nipple? So is it 2 centimeters, 3 centimeters in distance from the nipple? The size of the mass, borders, if they're regular or irregular. Consistency, again, important. Is the consistency smooth? Is it firm? Is it stony? It's rubbery. So obviously firm, stony, rubbery, again, is pointing to malignancy, whereas spongy, soft, less likely. And then how is the skin over the, any skin changes are there? So is the skin red? Are there any mass over, is the skin red only over the mass or in general, is the skin red? Is there any discharge or erythema? Then mobility, again, very important. As I said previously, you look for mobility. What is the degree of mobility? Is it freely moving or is it moving with the overlying skin? Next is fluctuancy and fluctuancy testing. So as some of you already might know, how do we do a fluctuancy testing? So you stabilize the mass and then you press on one side and you feel for the pressure differences on the other finger. So is it a fluid-filled mass? Is that why, like a cyst, is that why you have fluctuancy? Is it kind of sliding while you're palpating for it? Is it only single or multiple lesions? And let's go on to the next part. Now coming to another important thing is your axilla examination. So all breast examination should be accompanied by axilla examination. Some people also say looking for sternal tenderness should be a part of your breast examination. So in axilla, so you finished where they're at this 45-degree. This is very important because they're looking for that. Do you understand that now they have to change their position? So breast examination, you keep getting the patient to change from one position to the other. So axilla examination, they should now be sitting at the edge of the bed. And you need to support the hand that you're going to examine them, their forehand. So you have to support it. So if you're examining the right axilla, you use your right hand to examine and you use your left hand to support the patient. And so if you forget all of this, just the only thing you need to remember is right axilla, right arm, left axilla, left arm for examination. Next. So you need to palpate the axilla with the free arm and ensure that you've covered all the areas of the axilla. So what are these areas? As you can see in the picture. So we've got a few groups of lymph nodes. So you have the lateral group, you've got the anterior group, you've got the central group, you've got the posterior group, and the apical group. So make sure all these are examined. So remember the groups and state these groups. Then I'm going to look for all these different, and I'm looking for lymphadenopathy. This lymphadenopathy could be suggestive of one infection, and it could also reflect malignancy. And after this, I will finish off my examination by doing a complete cervical lymph node examination also. This also, once you're done today, please go through the Geeky Meds kind of demonstration of how to do a breast examination. Again, even though it's online, make sure you learn as if you're going to do it yourself. Next, they'll ask you about differential diagnosis of what is this breast lump that you've picked up. Obviously, we're looking for cancer, so the most likely is breast cancer. This is something I do want to, I'm not trying to sidetrack, but when you're asked to give differential diagnosis in physical examination, mostly it's differential diagnosis. Rarely is any treatment that they ask you. So when they're asking differential diagnosis, what is the most relevant goes first, even though we're looking for probably cancer or in a person who comes anxious and or everything else was negative, then most likely diagnosis will not be thyroid. So give what you think is more likely that just an anxious person, anxiety. Same thing in this situation. So even though we're looking for breast cancer, it could be fibroadenoma, it could be a breast abscess. So whatever's most likely goes first and the rest come after. So here the differentials would be breast cancer, breast cyst, fibroadenoma, fibrocystic disease, and breast abscess. Okay. Next, a quick, I saw one, and when at least when I was studying about gynecomastia, and I remember at least a few sessions before the one I went to, everyone didn't really know how to examine. So I thought I'll briefly tell you guys if you get gynecomastia. Gynecomastia is not just a breast examination, but it's kind of like, I describe it like an alcoholic man examination, because everything else will fit into that alcoholic man, will also fit into gynecomastia. So first thing, the wipe stays the same. Why I keep saying it is a lot of people, when they get a next kind of physical examination, they jump straight into the task. Take your 2 minutes to structure out what you're going to say. And this structure is generally reminding yourself that it's still the general, the vitals. It has to be that pro forma over and over again. Don't ever jump into whatever is asked. Like, please do breast examination. Yes, you'll do breast examination, but always start with, I'd quickly do a general examination on general appearance. I'll quickly take some vitals. So moving back, firstly, you're looking for BMI for high or big, high BMIs will also can mimic gynecomastia. Then you ask for the examiner. In online examination, you will get a card with the relevant findings. Sometimes they will give it to you at about 3 minutes or 7 minutes into your present or your discussion. So you will get the positive findings at the end to give you like your differential diagnosis, for example. Next, coming to the hands. So in hands, it's essentially, as I said, alcoholic man. So you're looking for alcoholic liver cirrhosis examination, essentially, basically. So that is clubbing, colonychia, leukonychia, palmar erythema. You're looking for pituitary contractions. Do they have sweaty hands, tremors, pulse, and blood pressure? Sweaty hands, tremors, and pulse is thyroid issues. Thyroid issues can also cause gynecomastia, so hand changes. Next, as I said, it's always the same pattern. That's why AMC, at the end of the day, physical examination in AMC is simple because it's just patterns. Making sure you stick to the patterns and you making sure you present those patterns. So BMI, vital, GA. Then we talked about hands and in the arms. In the arms, we're looking for any scratch marks, any bruising, any rash. And then coming to the face. In the face, we're looking for, is there any acne? Do they have any moon face like in Cushing's? In the eyes, if there's any jaundice, any anemia, any eye signs of the thyroid, which we've just gone through. Then parotid enlargement, again, as in cirrhotic liver disease. Next, coming to the neck. In the neck, again, we do a full thyroid examination and a cervical lymph node examination. I've been brief because each of these are being covered in other sessions, and I'm not going through it again and again. But in, let's say, gynecomastia was your whole case, then obviously do a full thyroid examination. You're going to explain to them how you're going to do a thyroid examination. If it's part of do breast examination and discuss about gynecomastia, or they give you findings of gynecomastia, then it's a bit more specific. So it time dependent but also question dependent. I'm trying to give you all the information in the slide so that when you get like bits of it, you know that this is the whole picture. Next, in the chest. In the chest, we're looking for spider neva, any bruising or scratches. Again, for portal hypertension, the liver issue. And then breast examination. Just like a female breast, you do the whole examination. Here, you might find like a very rubbery mass underneath the nipple, whereas in like oncology examination, you get a obvious mass. And so when you're explaining to the medical student here, you'd add like the examination. If you've already discussed it, then the examination for gynecomastia is exactly the same of inspection in those various positions and how we examine. But the only added kind of discussion point is it's more firm rubbery tissue that you may feel. Then axillary lymph node examination, same as before. Coming to abdominal examination. So once we do the CLD cases, you will I'll elaborate more, but it's a normal abdominal examination, looking for organomegaly, looking for shifting dullness, the usual. The only added things are you're going to do a DRE and a scrotal/testicular examination. And finish with visual fields. And as I said, if you've not already done it, a full thyroid examination. Why you're doing visual field is for any pituitary dysfunction. So the quick way which I was taught when you're doing examination, you feel like you're running out of time, and then I'll be like, I will also do a full thyroid examination, or I'll do a full kind of axillary examination or whatever it is. Just say you will do a full one and not explain the full. So at least in the last few exams, like, okay, he knows he needs to do this. He's just not had enough time to talk about it in the 8 minutes. So if you state it, that's good enough. Lastly, the differential diagnosis of when can you get these gynecomastia. One big beast individuals can get it steroid use, which is the case that we normally get there on, some sort of over-the-counter corticosteroids, or has hay fever, has been overdosing on these steroids. Others is pituitary issues, thyroid issues, Cushing's, CLD, testicular tumor. That's why I have to have a scrotal examination, and genetics, for example, Klinefelter's. That is it for breast examination. Any questions or anything you want me to go through again?
Hello. For the
Mm-hmm,
breast examination,
mm-hmm.
on ending, can you end by saying that probably if you felt a lump in the breast, you would like to complete the examination by maybe doing a mammogram or an ultrasound, depending on the age of the patient, and also a biopsy to complete the examination, or um is strictly restricted to physical examination?
So the important thing to remember is you're marked only on the task. So if you've got more time, adding some information is always better than kind of being silent. But you're not going to be, let's say the examination was just physical examination or differential diagnosis, then you're not going to be rewarded for your investigations or treatment plan that you've given. But let's say you finished all the examination quite quickly and you're running out of time. Then you can talk about, yes, you're right, mammogram, x-rays, doing a complete breast ultrasound, and then discussing the need for a biopsy and for routine, follow-up screening following that. So you can tell the medical student this is what you're going to do, but that will not give you extra points. But sometimes, let's say you forgot something vital or major. The examiner will be like, okay, I will reward him because he knows what the next step is. So you're not going to lose points for it, but don't be like, I want to talk more about the treatment, even though that's not in my task, and then kind of rush through on the task. So focus on the task as much as possible, but you can add more information at the end. Okay, the next one is pretty quick. I've just got a few quicker topics and okay, the next one is secondary survey. This I personally found a bit challenging in the sense that there's no structure. They kind of expect you to talk about everything and anything that is kind of under the sun will come into secondary survey. So how does secondary survey present as? So in secondary survey, they can present as unconscious person, or they are your intern working in a surgical department asked to do a secondary survey following a patient who's been admitted after an accident, an MVA, which is motor vehicle accident, or post a trauma. So you're asked to do a secondary survey. Here, things to be kind of mindful about is one, they will mention that they've already had a primary survey. So don't do a primary survey again. And a lot of people get confused and technically concentrate on doing a primary survey. So what is the difference between a primary and a secondary survey? It's a bit basic, but I feel like everyone needs to understand what they expect from us. So primary surveys immediately after an incident, whether it's trauma or anything, they come in. You want to make sure they're alive. That is the DRABCD protocol that they go through. So are they in any distress, danger, and you look for response, and the airway bleeding, breathing, circulation, disability. So that is your primary survey. Once you've established that their primary survey is clear and now they're vitally stable, then you're asked to do a secondary survey. In a secondary survey, we always assume that they're now kind of stabilized. But that doesn't mean we skip out on vital signs, but it's the next step after. And we're looking for literally injuries anywhere in the body, and then so that we can call relevant departments to take care of that. So that's the background. Secondary survey is a good question for online exam is because they want it's a lot to talk about. You can head to toe anything should be examined, and they're going to look for have you thought about that? And these are the ones they can have a bit more like secondary survey with Glasgow Coma Scale or assess the Glasgow Coma Scale. Then what is your differential diagnosis? What is your treatment? So they can ask more because it's just a lot of talking, essentially. So let's talk about what is this Glasgow Coma Scale. So as you can see, I've got the scale on my right. This is what I've been told. These three questions are all you need to categorize the Glasgow Coma Scale. Firstly, you don't need to memorize this. You will get it displayed on the screen. If it's face-to-face, you would have gotten a card for it. So what is the three questions that you need to ask them is just sidetracking or backtracking. Make sure, as I reiterate, the wipe still holds through here. You still wash your hands, and then you first ask for the Glasgow Coma Scale if it's not already displayed. It normally is. Make sure you scroll down, and that's the center of your screen before you start this task. The questions is the first thing when I'm doing the GSC scale, the first thing I'm going to ask is, can you open your eyes? So that'll give us your first, are they opening them spontaneously to the sound of your voice, to the pressure or not? So they would have already opened their eyes. Normally, if they've got GCS of 4, but if you needed to ask the question, then that already rules it out. The next question you ask is, where do you know where you are? So that'll give us our orientation, whether they're confused, they're making noises, sounds, or are they using words? The last one, can you please raise your hands? So you've given them a command that is six points. So you've given them a command and they're following through on the command. If not, then localizing pain. So this is when you need to add on, which is not included in my questions, is pain. So if you've give them a stimulus, are they localizing the pain? Are they flexing away from the pain? Or they've got abnormal flexion or extension or no movement at all. So this is the first thing. So the GCS scale. Next, coming to the examination. So as I said, it's literally head to toe examination. So start from the head. In the head, what are you looking for? Any lacerations? Is there any bleeding or swelling? Next, going to the eyes. In the eyes, the first thing we notice is the pupil. So look for the shape of the pupil. Firstly, here the step, and as I say, so don't rattle these information out. Obviously, today I'm rattling it out and I'm telling you, but I'm trying to stop and try to explain how you would say it. So in eye examination, firstly, Sarah, we're going to examine the pupil. So if they've opened their eyes spontaneously, it'll be easy for us to examine this. But if they're shutting their eyes tightly, it'll be harder to examine the pupil, and we have to skip that and concentrate on just general inspection of the eyelids. So, is the pupil in the right shape? Is it normal? Is the size all right? Do they have any raccoon eyes? What is that? Raccoon eyes is sometimes you can get bruising around the eyelids. And if they're opening the eyes while I'm looking for the size, I will look for the pupillary reflex and corneal reflex. If I have the equipment available, then I'll also do a fundoscopy, which will give me more information about the retina and within the eye. Then generally I'll look for swelling and redness. Next, moving on to the nose. In the nose, we're looking for, is there any discharge or bleeding, or is there any deformities? So why I'm trying to find this is sometimes you can get CSF rhinorrhea, or is there a septal hematoma? So these are important information I'm trying to gain from the nose. Everything is a sentence, everything has meaning, everything you have to include the your medical student or patient. So if most generally this would be a medical student because there's a lot of medical terminology, but if it is a partner and they just wanted to mess with you guys, then make sure you ask, do you understand what I'm saying? Do you have any difficulties? See if there's fluid around the brain. So all this, kind of use simpler English. Next is ear. So in the ear, we're looking ear, Sarah. Firstly, in the ear, we're going to look for any bleeding, any discharge, and we're importantly looking for a battle sign. So battle sign is when you've got bruising around the mastroid. If you're talking to layman, it'll be bruising just behind the ear. And then most importantly here, it'll be good to have an otoscope. Previously, we needed a fundoscope. So otoscope to look at the eardrum. Sometimes trauma can lead to eardrum rupture. Next, I'm going to move on to the mouth. Mouth is important in the sense that firstly, we're looking for their breath. Now, GC is very low. We don't know if it's alcohol. So we're looking for alcoholic breath. Feta hepatitis. What is feta? What Fetor hepaticus. So what is this? This is the strong musty smell that comes off alcoholic. So we're looking for this. Is there any loose teeth? Any bleeding in the gums? Is there any infection? Is there a foreign body that I can see in the mouth? Have they bitten their tongue? Could this all be just a seizure and now they're in the lucid phase or in the stupor phase? So I'm going to look for those. Then moving on to the neck. In the neck, what I'm looking for is firstly neck stiffness. Is there any neck stiffness that I can appreciate? Any hematoma? So I would, how you would describe this again, each of them, make it a blanket rule because it's kind of joined hand in hand. I'd say I would first inspect and then later palpate each region as I go. So in this, so neck first, I'll inspect for any bruising, any swelling, any bleeding that I can, or obvious signs of trauma. Then I will palpate for stiffness, any palpable hematoma, any emphysematous crepitus. Again, fracture leading to gas trapped in can be felt. Air or gas that is trapped in the subcutaneous layer of the skin, essentially. That's what we're looking for. Now coming to respiratory examination. Again, if you get this question, it's a really good question because it's just every knowledge that you've gained in your preparation, you're just blurting it out. So you're going to do a full respiratory examination, which when we do the respiratory session, I will go through in detail. But here the key point is looking for any rib fractures. Then same thing with cardiovascular examination, looking for heart sounds, looking for essentially any murmurs, any kind of ectopic beats, bradycardia, all of those. Then in the abdomen. Abdomen, again, firstly on inspection, I'm looking for, is there any bruising, spider nevi, any rashes, petke, visible distension masses, and most importantly, they love this, is any insulin injection marks. And palpation. On palpation of the abdomen, I'm looking for organomegaly or tenderness. Any scratch marks, or and oh yeah, sorry, no, any scratch marks. After that, we talk about auscultation, obviously, for bell sounds in the abdomen. Next, moving to extremities. In the extremities, either legs or arms, what are we looking for? Any rashes, any petechia again, any purpura, any injection marks, any bite marks, any scratch marks, and more importantly, any medical alert bracelets. So it's very important. Most people either have a medical alert bracelet, some people even have tattoos of their allergies. So I will look for those. Then CNS examination, I'll do a complete CNS examination, but more importantly, I'll look for the tone and reflexes of the limbs. Then I will finish by doing a genital examination. Don't forget about that. Any injury, any scrotal swelling. And finally, do anal tone and again looking for spinal injury, looking for the back, and then if I've noticed there's no other fractures, then I will roll the patient and do a back examination and spine examination. If a suspect fractures or spinal cord compromise, then I will get an assistant and we'll do the log roll. So everyone remember this word. If there's one thing you take out from today, this is the word log roll. It's a very important term, and they again expect it'll show that you know the medical system. So you want to protect the spine. So you hold the spine kind of firm and then you roll them to their side. And then one person will examine the back and then we kind of flip them back. So it's called a log roll. So why is this person's GCS reduced? Likely they've drug overdosed. Other causes could be meningitis. They've had a cerebral vascular accident or incident, hyperglycemia, any head injury, electrolyte imbalances, or any psychiatric issues or problems could have led to this. So you'd finish with that. So if secondary survey is the kind of task, it's very simple in the sense that you just do a head to toe, talk about everything you remember, each systemic examination, only highlighting the positive findings and positive things that would add to kind of your differential diagnosis. That is it.
I have a question.
Mhm.
I think I've seen a recall in which the roommate of someone brought him to the hospital in a coma.
Mhm.
And I think the tax was so you were supposed to do a physical examination. So I think it's along the lines of a secondary survey kind of picture, a
Mhm.
primary survey, secondary survey kind of picture. But in this situation, will it be prudent to I know it's not part of the task, but will it be prudent to just take a quick history from the um the roommate kind of to kind of guide your examination?
Mhm.
Would you advise something like that?
Um, Obviously, it'll depend. If you're teaching a medical student about it, then there's no kind of friend to ask information. It will be sometimes it's kind of like a sneaky way a lot of people used to examine, especially in face to face, is while you're examining, you'd ask like questions to kind of back up your guide. So be like, oh, look, I'm looking in the hand for insulin marks, and then be like, oh, is your friend diabetic? Have he be what is his regular medication? So you can do like a double kind of question plus examination kind of technique. I think that would be safer and better than having starting off with an introduction. In online examination, the disadvantage is you're not going to get the stick to your task, which is what in face-to-face they keep saying if you kind of deviate out, the examiner will be like, please stick to your stuff. So here you're not going to get that. If you deviate out, you'll just get a big zero for your task and then they'll just listen to you essentially. So to prevent you from that, always stick to your task. But yes, you're right. You can get some information. Let's say you were asked to do this, coma examination and explain to the roommate as you do the examination. Then obviously, yes, it'll be a good idea to ask the roommate some history as you explain the examination findings. In that coma student, they're trying to they're trying to establish that you've identified as like a high risk situation, and this might be a primary plus secondary. I don't remember the whole recall, but Make sure you always check for vitals. And in online exam, there's no such thing as I will move them to resusc, cubicle and stabilize them. You have to tell them what you will do as instead of like physically talking about it. So firstly, if I find that the vitals are not are unstable, this is the steps I'm going to take before I move on to my physical examination. If I feel like I can't progress, I will escalate, or you tell your medical student, I'll just call my senior while I do the next step. So you still continue with the task, but just use words to kind of express the urgency of what you're going to do next. That is it for this. Okay, we'll take like a 5-minute break and then I've got 2 more topics to go through. Okay, let's continue on. Next, kind of case that we're going through. I've just got 2 more topics I wanted to talk about today. One is peripheral vascular disease, and the next one is headache. So in peripheral vascular disease, this is in the sense I feel it's a quick and easy examination to get. Essentially, it's the same as doing like a musculoskeletal examination and a lower limb neuro examination kind of combined. So you do both of them or when we're practicing for it, and then you combine them together to get this examination findings with a few more special tests. So as I've been on and on, the usual wipe, general appearance, and gait. So gait is the added thing that is important here. We're looking for any painful gait, if there's any abnormal gait. We do have another session on gait, so that I'll describe more, but essentially you want to document mention what type of gait this patient has. So sorry, I just skipped on this. So how do they present? Normally they have pain on walking. It's a good kind of description. You have a man who's probably old, he might be diabetic, a smoker, hypertensive, some other kind of comorbidities going on, and he's got pain while walking, and you're asked to examine him, give diagnosis or differential diagnosis. Sometimes, so as I keep saying, when you get a physical examination, it's less likely you're going to get treatment of management or counseling combined to it, because the physical exam, they expect you to use those 8 minutes to detailedly describe all the physical examination, maybe 1 minute for your differential diagnosis. So use those 7 minutes to do your physical examination and focus on that. And while I'm on that note, coming to differential diagnosis and diagnosis, always back up your differential diagnosis, which I haven't been doing in this past, or not explicitly. So when you're saying, let's say, breast examination, I felt a firm differential diagnosis, breast cancer, fibrocystic kind of disease of the breast, fibroadenoma. So breast cancer likely because I felt a firm nodule, not fibrocystic because I couldn't have fluctuancy. It did not, on examination, did not feel cystic. Fibroadenoma still possible, but there is skin changes, which is less likely to be seen in fibroadenoma. So always justify each of your diagnoses. That's why it shouldn't take 1 minute to list out DDs, but it takes 1 minute because you're explaining each of your DDs. And that is the game changer. So make sure you just don't bullet points. As I keep saying, it is not bullet points. The exam is a discussion. Okay. Now let's get back on track. So vitals, the usual. Now coming to all limb examinations. So this, when we do musculoskeletal, when we do lower limb, the top mnemonic or the top five are the same. So you always look for first scar, swelling, redness, rash, bony, and muscle deformities. That is stock standard. Every case that involves a limb, you need to talk about this. Apart from this, what do you need to add? Is there any skin changes? So color of the skin. Is the skin dry and shiny, or is it pigmented? What is the hair distribution? Next, you talk about the nails. So in the nails, is there any nail changes? Are the nails discolored? Are they coming off? Is the foot discolored? Is there any ulcer or gangrene in the foot that is visible? Um, is there any loss of limb or loss of toes? Make sure you look between the toes. So you ask the medical student, very important, to spread the toes apart and have a look inside for infection or any ulcers. The last thing you need to do in your inspection is lift the foot up. If the patient can lift them up, you can ask them to lift it up, or sometimes you might need to support their leg and you have to examine the heel. So again, any ulcers, especially pressure point ulcers. Next, coming to palpation. So in palpation, first is temperature. So in temperature, in a healthy individual, both limbs should be symmetrically in temperature. They both should be warm. That means that they've got adequate perfusion. Let's say one limb is cooler and more pale. Again, that shows that there is poor arterial, very important arterial perfusion. Next, we look for capillary refill time. So press at the distal node, whether it's the toe or the pulp of the big toe or in the pulps of the hands, the fingers. You press and then look for capillary refill time. Then coming to pulses. Pulses are important because you need to explicitly state how you would measure these pulses and describe at what points you would measure these pulses. So first is, since I said this man came with leg pain while walking, you do your distal lower limb pulses. So first is the dorsalis pedis. So what is this dorsalis pedis pulse and how will you measure it? So dorsalis pedis, you have to measure it it's the anterior aspect of the foot, the first point. It's lateral to the extensor hallucis tendon. So this if it's a medical student, obviously you need to explain it to them. But if it's just the, partner or the patient, just the front of the foot, kind of just above the fingers, I'm just going to feel for your pulse like you normally have in your arms. I'm sure if you had your GP feel for your pulse, I'm going to do the same thing. On that instant, I'm just sidetracking again because I feel like these were the points that I missed the first time, and the second time, that's what I remember. It's a conversation. I will guarantee all the 10 people who are on this class today, if you have a conversation during the exam, talk to the whoever the role player is and make it as genuine and real situation, and have very minimal kind of, you don't remember the insertion of the extensor hallucis tendon, that is completely all right. You will still pass. They're looking for, are you safe? Do you know what you're doing? And are you good at communication? So communication is 90% of your exam. So I'm sure you all, this is just recap what I'm telling you. It's how you communicate, and how I'm talking essentially is what you need to do in the exam. So you'd be like, as you know, I'm sure you've had your pulse check before. In the arms, we're doing the same thing, but in the foot, to see if there's good blood supply in the foot. Easy. So that you've explained dorsalis pedis. But for your knowledge, the others are posterior tibial. So posterior tibial is the medial, or kind of just anterior, or the border of the medial malleolus is your posterior tibial. Popliteal is they're lying down prone. You ask them to flex their knee joint, and then it's in the popliteal fossa. Femoral is in the inguinal, kind of mid-inguinal point. Brachial we know, and radial we know. So just a quick kind of explanation about the femoral pulse. So the femoral pulse can be palpated in the mid-inguinal point, which is again located halfway between the anterior superior iliac crest, spine, and this pubic symphysis. So when you're explaining to a medical student, this is your, little extra bit that you talk about. Oh, do you know, medical students, Sarah, where the femoral pulse is? So this is in the mid-inguinal point. So how do you know that? You look for your anterior superior iliac spine. Once you found that, you also find the pubic symphysis, and between these 2 points is where you feel for your femoral pulse. Now let's move on to auscultation. Why are we auscultating these points? So we're going to auscultate your abdomen looking for bruit. So what is this bruit? This is this abnormal sound. So it's like a turbulent sound that you hear in arteries. If you're explaining to the patient, you're like, so we're looking for abnormal sound. So normally, like a river that's flowing, it should be free flowing. But if there's a block like a dam or anything that's obstructing it, it'll make a different sound. So you always give analogies. Analogies are really good, especially when you're explaining to patients or attenders and family members. So where are you auscultating from? Right in the center. Make sure you explain this to the medical student. You're looking for aortic. And then on both right and left, renal artery, just right and left to the midline. And then lower down, you can get right and left iliac arteries, and then right and left femoral arteries. Next, coming to Burgess test. So Burgess test, this test is to demonstrate poor lower limb perfusion. So what you need to do is, first the patient should be supine, so they'll be lying down. Then you need to stand at the bottom of this bed, like the guy in the picture here in the white shirt. He's standing right at the kind of the foot end of the bed. And you need to raise the patient's feet up to 45 degrees, and you need to hold them there for 1 to 2 minutes. So in these 1 to 2 minutes, you are observing for pallor. So if there is rapid pallor, then we know that's our given answer, that they've got severe PVD. If the limb develops pallor, then we can also note at what angle they develop pallor. So that is called Burgess angle. So from the bed, just a little bit higher, they get pallor. Lower the angle, severe the ischemia. Or you can lift it higher, 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 up to 45 degrees, and looking for when they get this pallor. A healthy leg or healthy toes should remain pink even at 90 degrees. They should not get pallor. So that should be normal. So Burgess angle, as I said, less than 20, that's considered severe limb ischemia. Now, once the time limit's reached, so you've put them in that position for 2 minutes, then you ask the patient to sit, as in this guy in the red shirt, legs hanging down at the side of the bed. And now you're looking for 2 things. One is if there is initial blush, and then later is there reactive hyperemia. So blush means what? All the deoxygenated blood is now passing through this ischemic tissue. Then the leg will become red, as this is like a secondary response of this post hypoxia. You'll have all those tiny arterioles dilating. So blue is because all this deoxygenated, there's not much supply, so there's deoxygenation blood passing through, becomes blue, and later will become hyperemic because in response to that, all the arterioles are going to become large and dilated. Next is the ankle brachial index. So this is another important thing that they'll ask you to explain to the medical student. So this is a very good measure to look for peripheral blood supply. It is non-invasive and can give us a lot of information. So how do you do it? You're measuring the systolic blood pressure. Again, you can use an analogy. So it's like how we take blood pressure in your arm. It's the same thing I'm going to do in your leg. So I'm going to take the systolic for the medical student, or just say blood pressure if it's to the patient. Systolic blood pressure in the ankle, that is the posterior tibial, and the forefoot, which is the dorsalis pedis. So either or you can use, either using a blood pressure cuff or a Doppler. And at the elbow to measure the brachial systolic pressure, and then you divide both of them, and that's how you get the ABI. So how you kind of classify, I've got this picture online, but essentially 0.9 to 1.3 or 1.4 is normal and understandable. Anything more than that, heading to 1, is acceptable, but they will have symptoms of intermittent claudication. So they will initially get pain, and then they can kind of keep walking and then overcome that pain, and then they can keep getting it back. So acceptable in the sense that we don't have to do anything imminently and more lifestyle modifications, but understanding that it can later progress. Anything less than 0.5 or sitting in the red zone is when we've started reaching the area of ischemia. And anything definitely less than 0.15 is severe limb ischemia. So that's, I've got severe in the last column, it's one less. So 0.515 means they're going into stages of gangrene. After doing this, the next thing we talk about is sensation. Again, when we're doing lower limb examination, I will talk to you in detail about how to do light touch, vibration, and how you examine it. But essentially, aim is in the sensation examination, you start distally and you're looking for paresthesia. So how you would explain this to a medical student is, Sarah, why is sensation so important? Is one, we're trying to look for because now they're not getting much blood supply, because and this will result in ischemia. When ischemia of tissue happens, even the nerves can get affected, and that's when you will start off with one, paresthesia. That's when you get altered sensation. This can later progress into complete loss of sensation. That's why sensation is so important to pick up. So how we just look for gross sensation and peripheral sensation. So start off with light touch. Start distally. So the furthest point first. So your toes. If you have sensation in the toes, then we don't have to do the rest of the examination. It's assumed that the sensation's intact. For this is only in peripheral vascular disease. When we're doing neurology in upper and lower limb, that's a different situation. In that you need to examine all dermatomes, because that can be nerve root / upper cord lesions. Whereas here it's just peripheral sensation. So if distally you have it, then you don't have to do proximal sensations. If they're intact distally, again, no further assessment is required. If reduced, then you need to assess the extent. So you can have paresthesias in the fingers, but as you come more proximally, you'll have a definitive point where there is normal sensation, and that's what you're picking up. Sometimes it could be the whole limb or below the knee, below the foot, where these paresthesias exist. After that, we do vibration sense. We'll do proprioception. Again, we'll go through these detailed in another session. We look for tone power reflexes. Make sure in peripheral vascular, there's always some cause, right? These are peripheral vascular is a complication of something, diabetes or complication of alcohol, complication of cardiovascular. So do a cardiovascular exam, do a complete upper limb neurological exam. Make sure you don't forget to do back examination and a neuro and straight leg raise test for looking for sciatic nerve injury or issues. That is it. Any questions for this section? It's pretty simple because we're going to hopefully cover neuro exam later on. That'll be more in depth of what we need to do. Okay, if not, we'll move on to our last section, which is headache. They love giving this for online because it's just a lot of talking and a lot of just things they need to. You don't really have much on if they gave this as a physical examination station, they've got not much for them to judge or test you on. It's all just talking, 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 which is what they want in an online. So this is an ideal online exam. So what they come with. Hey, the examination, it could be children with headaches. So that's the only kind of added thing. I'm hoping to do like a session just for pediatric cases. So I will explain more on how to do it. But headache can be like these 10-year-olds, 9-year-olds with headache, or stress headache, cluster headaches, or even bruising, laceration, like an injury-driven headache could be the differentials. But remember, this can be a case where it's a pediatric patient we're dealing with. So as we start off with wipe as usual. Next, coming to general appearance. In general appearance, we're looking for any facial asymmetry, any deviation of the mouth, drooping of the eyelids. Next, vitals and analgesia. Obviously, they've got a headache. We have to make sure, do they want some paracetamol or any simple analgesia? Vitals are important if you're thinking about head trauma. This in online less likely, but if this was offline, it can be into like a resuscitation, subdural hemorrhage kind of case. I haven't seen one of those, but it can, meaning it's a situation that you need to understand that I want to make sure the patient is vitally stable. So tell your medical students, Sarah, it's very important, especially in headache. We've got a range of differential diagnoses that can result in headache, from as simple as having sinusitis, cold, post-viral, to trauma, bleeding, intracranial infection. So it's very important to make sure they're vitally stable before we progress. Next, you start off with a usual head, eye, ear, nose, and throat examination, which we'll go through each one. The first one is head. So in head, first inspect. So inspecting for any laceration, any aberrations, any bruising, bleeding, hematoma. Then battle sign, which we already know, it's essentially mastoid, kind of over the mastoid, some bleeding, so suggestive of intracranial trauma. Then you palpate. Again, palpate the head for tenderness, any depression suggesting fractures. And then you palpate for any swellings, any bleeding points, especially on your gloved hand, if you can see that it's red. Then, especially in older guys, not really in children, is temple artery tenderness, redness, swelling, or even visible pulsation. So, giant cell arteritis can come with, temporal artery tenderness. So you need to palpate this, and then you can feel this like thick, hard artery. Again, please don't say this in a pediatric case. So these are very important. There's actually very few cases that kind of overlap. Pediatrics, we get more rashes, vomiting, upper respiratory cases. But headache is one you can get in adults versus peds, and they can similar, in our head, we'll just be going through the differentials. Don't overlap and say something that would be kind of pediatric specific or adult specific in either or cases. You will definitely be negative marked. So next, coming to the eye. In the eye, you're looking for redness, any discharge. You look for the pupil, the size of the pupil, the shape of the pupil, pupillary reflex. Again, same like our secondary survey, raccoon eyes. And then you palpate over the eye for any tenderness or facial fractures, essentially, or ocular fractures. Ear. In the ear, again, redness, discharge, swelling, redness. You can use an otoscope to look inside the ear. In the eye, also, you can use an ophthalmoscope. Nose, you're looking. Oh, on that note, please remember or learn, watch some YouTube videos on how to use an ophthalmoscope, because you have to I think it's in that cranial nerve examination, you have to like kind of explain how to turn on an ophthalmoscope, so you have to learn how to explain it also. So just on a side note. Next, coming to nose. In the nose, you're looking for redness, any discharge, any swelling or tenderness. So same thing. In eye, ear, and nose, you're looking for the same things. In the throat, there's a few extra spaces which you're looking for the gums. If there are any loose teeth, any gum infections or swelling that can cause pain, any redness or signs of infection. You're looking for the pharyngeal wall for any erythema, tonsillar enlargement, exudus, again, um, sinus tenderness, um, and importantly, temporomandibular joint tenderness or pain. So you ask the patient to open and close the mouth while you feel for tenderness over there. Next, important is the sinus tenderness. So sinuses, what are they? This is again, remember when you have to explain a bit more to your medical students for that extra brownie points. So sinuses, there are a few sinuses we generally look for, frontal and maxillary sinus tenderness. So Sarah, in the sinuses, what are they? They're these air-filled cavities in the facial bone. So the maxillary sinus, which is located on both sides of the nose, and it's near the cheekbone and quite easy for us to palpate. The other one is the frontal sinus, which is located just above the eye. And again, near the forehead, again, we can palpate for it. We've got a few more, like the ethmoid sinus, which is located in the nasal bridge, which is harder for us to palpate. So I've got a picture here. As you can see, the frontal sinus is in the forehead and just above the brow creases. You've got maxillary sinuses on either side of the nose. And as I said, ethmoid, which is a bit more deep. In this, you do what we call it. Firstly, you look for tenderness. So press on this. So press on the cheek, just lateral to the nose. And then you also press against the brow and underneath the brow and forehead for frontal. Next thing you do is trans-illumination test. The trans-illumination test, if positive, again means that the sinuses are fully blocked. So you ask the patient first to tilt the head backwards, and they open their mouth. Then you shine the light from the mouth towards the maxillary sinus, okay? So towards like the outer side of their nose, near the ala. So this will tell us if the transluminance test is positive, that means the sinus is empty and the light is able to kind of shine through. If the sinuses are impacted, they're blocked off, then the light won't be able to shine through. Next, coming to the neck. So in the neck, we again look and feel. So you're looking for any obvious swelling, injury, or deformities. Other than that, you feel for muscle tenderness, any stiffness, or are they able to do movement? So we will discuss movement later, but essentially it's up and down, side to side, and kind of rotatory movements of the neck. This is a look for like cervical spondylosis, any cervical injury, fusion, all of this can be picked up. In eye examination, I know we briefly spoke about what we look at eye examination. Headache is very important to do a full ocular examination, including visual acuity, distance, and near vision. Not only like tumors and stuff affect visual acuity and visual field, but normal refractory errors can result in headache. So it's to rule both of them out. And you need to do a full cranial nerve examination and upper and lower limb neurological examination. This is the point where you say, I will finish off my examination by doing a full cranial nerve examination as well as an upper and lower limb neurological examination. If you don't, even if you have time, no one expects you to do a whole headache examination and then talk about upper and lower limb. It's more you just mention that you will do the examination and if there's any positive findings or what you're looking for. And then they will ask you for your differentials, or the rest of the question will continue on. That is it for today. I think I zoomed through it a bit more than I would have liked. Do you guys have any questions or any concerns or anything you want to ask me before we finish off for today?
Yes, ma'am, I have a question.
Mm-hmm.
Suppose in this case of pediatric headache,
Yep.
Should we focus more on the general examination, the inspection about the head, the eyes, the ear, or should we focus more on the cranial nerve examination and the upper and lower limb neurological examination? The
So
focus should
most,
be,
yeah,
yeah.
sorry. Oh, sorry. No,
Okay.
most of the time it should be a full head, no eye examination, because you will get a specific upper limb, lower limb examination, questions either way. So they will never expect you to do a neurological examination when they give you a head examination. The whole point of a headache examination is they want to know, do you know that the differentials for headache is not just neurological, but there's, from sinusitis, injury will cause it. So they're trying to pick that up. So never, I don't think I've seen a case where you have to do a neurology exam for a head, but you have to mention it. So
Okay, ma'am.
don't forget to mention it. But yeah, no, you don't have to.
Okay. Thank you.
That's it for today. Yep, that's it for today. And any other questions or we're done? In general, little homework for everyone, please go and watch those videos, because I did explain it, but it's different listening to it and actually watching someone do the thyroid and breast examination. So just YouTube those videos and watch the posture and how they do each step, because that's what you need to explain to the medical student. So sometimes we'll be like, oh, it's like basic knowledge. It's never basic knowledge. So washing your hands might be like a basic thing, but in the exam, washing your hands, drying your hands, like even these little things will add up. So make sure you explain everything when you're kind of describing a procedure, especially for the physical examination. Okay. That's it then. Thank you, everyone, and I will see you next time.